Well, good morning, everybody. We're going to go ahead and get started. Thank you so much for being here. Thank you all for making it through the third day of PO. This has been a wonderful event, and the stalwarts that have made it for all 3 days, we appreciate you. For those, just some housekeeping issues, for those that are eligible for CLE credits, this panel is CLE accredited, and there's a sign-in sheet by the door. If you're here in person, if they're online, there's a QR code that you can access that will allow you to get credit if you're online. I want to thank our panelists very much for being here. I'm thankful that you're here, by the way, because yesterday was a little bit tough for you all to make it, but it's okay. You were getting your work done. But thank you. Wanted to introduce both our panelists, Representative Brad Buckley at the end, elected to the Texas House in November of 2018. During the 86th legislature, served on the Appropriations Committee, the Agriculture and Livestock Committee, and the Local and Consent Calendars Committee. Currently is also practicing veterinarian in the Killeen area, and he's a proud graduate of Texas A&M. I've never seen a non-proud.
I don't know. Not in the room today. I usually pack the room with Aggies. But
loud and
not
proud.
Today. There's one.
Representative Tom Oliverson is a physician. He represents Texas' 130th State House District and serves on the Calendars, Natural Resources, and Insurance Committees in the Texas Legislature and is the Vice Chair of the House Republican Caucus. Named Best Freshman Legislature of the 85th legislative session by his colleagues. In his second session, was named by Texas Monthly as one of the best legislators of the 86th session. Serves on multiple healthcare task force, including the Texas Conservative Coalition, American Legislative Exchange Council, and National Conference of State Legislatures. He is a board-certified anesthesiologist and a partner at U.S. Anesthesia Partners. Thank you, gentlemen, for being here. I want to start off by just talking about healthcare in general. We're talking about patients post-pandemic, getting care. We want to focus on that issue. One thing that I hear, and I know that you all hear quite often, is that the free market has not worked in healthcare. Well, I would challenge that by saying that we haven't had a free market, by and large, in healthcare for over 60 years. And it's high time that we get back to it. And so one of the first things that we want to talk about, actually news of the day, is something that's come up due to an executive order that was put forward a couple of years ago, and it's been in court, and recently has taken effect on January 1st of this year, and that is the healthcare price transparency, where hospitals are required to post their prices, their negotiated prices with the insurers in an easy-to-read format on their websites. And I want to have a discussion with you, gentlemen. Tell us your thoughts, your ideas about how that can be helpful for patients, how it can be helpful for making healthcare more affordable.
Well, I appreciate the question, David. I think that is the question, and that is the piece of information that you need. I was actually at the White House the day that President Trump signed that executive order and was very proud to be in the audience with a number of physicians from around the country applauding his efforts, because this is something that we've known for many, many, many years, and that is that healthcare functions unlike any other industry on earth in that a person purchases a product without actually knowing what it's going to cost them until about 30 days later. Imagine if you went to the car dealership and you bought a car and you couldn't find out what it was going to cost you until after you'd been driving it for a month. I mean, it's just the most ridiculous thing. And as deductibles go up and patients' cost-sharing portions go up, these things that used to be reasonable, affordable have become more and more unaffordable. So being able to know what a service is going to cost you out of pocket before you sign on the dotted line, I think is a fundamental right for every American. I think that right should extend into every sector of the economy and the marketplace. And quite frankly, I don't think you can have a free market without having that information. So it's the thing. And I guess the other thing I would just add is, historically this has been hard to get to. There's been resistance, I would say, by all of the stakeholders that are involved, not just the hospitals, but the insurers, the providers. These are negotiated rates. You hear all the time, and in fact, David, you mentioned the lawsuit. You hear all the time that, well, we can't tell you this because it's proprietary, it's confidential. We secretly negotiated these prices, and I don't want my competitor knowing what I'm getting paid because then I lose my competitive advantage. And the truth is that when that went to court, it was found to be a very flimsy argument and was rejected. And so I'm glad to see that we're finally over the hump on that.
Yeah, and if I could piggyback on that, proprietary usually means secret. It's secret and personal to that organization. And it's never usually disclosed. When it's disclosed, it's no longer proprietary or confidential. Well, everybody gets an explanation of benefits with that negotiated rate on it. So it's not a matter of if you're going to see that information, it's when. Well, I'd prefer that you see it before you get the service. So that's the argument that we're making. Dr. Buckley.
Wow. Of course, Representative Oliverson makes such a great point and has such a unique perspective living it every day. But I would offer this as well, as I think the lack of transparency is one of the big disruptors of a physician-patient bond, because you have no idea of what things are going to cost. There is no way to truly evaluate what you're getting. I'm just a simple animal doctor, but my way of delivering health care to the animals that come in on behalf of the folks that walk in is based upon transparency. They can make a choice. And certainly the healthcare system for humans is much more sophisticated. It's much more, there are many more hurdles. However, there is something that works when folks know what things cost and they can make their own decisions. And I will tell you, it makes me a better practitioner because they have the very easy ability to call down the road and find out what the same thing costs. Then they can make a judgment. I'm going to go to Buckley. He's $10 more, but I think he can provide value for that $10. Or they can make a choice to go elsewhere where they feel like they want to save that. And I think once we do that, we'll empower the patient, and I think we'll empower physicians to be more creative, to gain efficiencies. And so I think that is a key thing that if we're going to reform this system, if we're going to make sure that we take it back to physicians and patients leading the way, then this is one of the areas we must do so in transparency so folks know what things cost.
I appreciate that. The order that went into effect on January, unfortunately, even though they had a year and a half, almost 2 years to prepare, based on our cursory review, less than a quarter of hospitals in the state of Texas are in compliance. And it's a real question mark as to whether they will be compliant, because the penalty associated is only $300 a day. For those of you who don't want to break out your calculator, that's $109,500 a year. That would be the penalty, and that's a minuscule amount of money for those facilities. Why should the hospitals do this? Do they have an obligation to their communities? Do they have an obligation to the taxpayers? Give us your thoughts on why the hospital should move forward, and what do you think Texas will do about this moving forward in the legislative session?
I think they do. I think they do have an obligation to be transparent. I think that's something that every patient in Texas deserves. And I also believe very strongly on the flip side of that I think if they were transparent about their pricing, not their what they charge, but what the patient's actually going to pay. And that information was made public along with quality measures data and outcomes data, which they're already submitting to the federal government anyway. Right. I believe they could fairly compete on price and quality. And I think that you would find very quickly that there's a market for a hospital that's going to deliver a good value. High quality care at a reasonable price would become a very popular, busy hospital. And I think they can compete. Yeah. I know they can compete. But there's just sort of this comfort in, the patient comes to have a baby, the obstetrician delivers babies at 3 different hospitals, and the patient can't find out what it's going to cost them out of pocket at any of the 3 hospitals before they make that choice. So they end up choosing based on a friend's recommendation, or whether there's valet parking available, or if the rooms look nice, or or whatever, right?
Yeah.
And so I do think they could compete effectively, and I do think that they would continue to be profitable, and I do think that they would continue to be successful. And the other thing, I'll just say that, I'm just going to throw this in here because it seems like the appropriate time. It has always frustrated me as a doctor that we make this assumption based on this lack of transparency that all providers are created equal, when in fact we know that's not the case. Many of you are familiar with the Geico commercial where the patient is about to have surgery and asks the nurse, so what do you think of Dr. So-and-so? And the answer is, he's okay. So the other big part of this transparency, it's not just about cost, but I think a lot of time patients are shielded from being able to figure out where the cream of the crop really is located, and who are the people that are just sort of C- healthcare providers. And I think that's really egregious. I have always felt strongly as an anesthesiologist, I am happy to compete on price and quality any day. And I believe that me personally as a provider, I can rise to the top in an environment like that. But I have worked with people, and I've worked in facilities where I personally wouldn't let my family members go. And you can't, the problem is that you can't, as the public, find that out. And I also think that price transparency, to a certain extent, combined with quality transparency, actually allows providers who are high-quality providers to be incentivized financially for the quality that they provide. And those that are barely scraping by, there's no reason why a doctor who does a C- job should get paid the same as a doctor who's an A++ doctor, right? I mean, we see that in cosmetic surgery a lot, where you have plastic surgeons that charge an arm and a leg for cosmetic surgery, and they're surgeons to the stars, but they're worth it. And we have orthopedic surgeons that operate on famous sports stars, and people are willing to pay to go see these individuals. So I just think that there's a lot to be gained, and I do think that the hospitals could be very successful if they would just embrace this.
I agree. And I would add another metric. I think there are several. Price is a great start. Price, quality, and then even the quality of their billing. Because the billing processes in many of these hospitals is egregious and creates such stress for the patients that they end up sicker than when they got there in the first place, which is a big reason for why I'm sitting in the chair that I'm sitting in today. Dr. Buckley, what do you think we can do in the state of Texas for making this more of a reality and something that the hospitals will want to participate in even more?
I think it's all about creating an environment where that cream rises to the top. You will incentivize the high performers, the high quality folks to seek an environment, seek a hospital where they can take their skills and earn the maximum, the maximum income that they can. I mean, that is what a market does. It separates, everybody into different levels of abilities, and the public deserves that. And I'm telling you that, in my opinion, the lack of transparency, is creating not only a lot of costs for patients, but it's creating costs down the line. And the reason for that is that, my market, in the way that I operate, that's very, very transparent market, as I can create a market where a lot of, many folks want the services I offer, I in turn can lower the cost of my supply because there's more demand there. Now I think all of these things, all this entire system that's so big and so important to us that literally operates outside of normal market forces is what's, it's absolutely the reason that, I have our family, we have a $10,000 deductible, which if you're healthy, praise the Lord, means you basically don't have health insurance. and you go to the doctor, you have no idea what anything costs. Nobody else, no other industry or segment of our economy could operate like that. And so, that is the key thing for me is how do we get the cost down? What can Texas do to make sure that folks can have access to that information and make their own choices? And I do believe that in the end that hospital systems will do better, and costs will throughout that supply chain go down because of that.
The great majority of Americans in this country never hit their deductible. So many of us are cash patients. So it's important that we see these prices. I know many of you don't read legal briefs, and not for fun anyway. But if you do have one that you are going to read, I would recommend you read the arguments from the American Hospital Association, the appellate court, because in addition to saying that the price is unknowable, they said people just don't really care. It's too complex, it's too confusing. It really doesn't impact them. All they want to know about is their benefits. So let's just provide them with an estimate on an average and allow them to know what their benefits are. Let me tell you why that's false. Because we're cash patients, because deductibles are so high. If I were, let's just say I had an insurance product and my deductible was $5,000, and I have two hospitals in network. One is part of a big system, and one hospital is one that stands on its own. The one that's part of a system, leveraging their market power in their city, can negotiate better rates with insurance companies. So if I want to get a CAT scan, and they both have the same type of equipment, this one may be a $2,000 negotiated rate with my insurer, and this one could be a $1,000 negotiated rate. If I have a $5,000 deductible, which one do I want to go to, all things being equal? Well, the one that'll save me $1,000. So it is absolutely important to individuals and to our communities, and I hope that this will be something that we will see more and more of. Gentlemen, going into this session, it's going to be a challenging session, but I was encouraged to see the unity in how legislators were focused on Texas and Texans. Facing a deficit such as the one that we're facing, what do you see as potential solutions for making healthcare more affordable? How do we become more efficient? How do we bring down the cost by incorporating the things that you've discussed, like competition and other market forces that make sense and that do typically work?
Well, fortunately, I think, two things. I want to go back to something you just said, and the insanity of the argument that was made with regards to patients not caring or not knowing, not caring, is that the whole purpose of having a deductible in your plan is to inspire the patient to be more cost conscious. So then to say that it's not knowable and nobody cares is truly insane. It just literally doesn't make any sense.
It's offensive.
It is, because that's exactly what deductibles are designed to do, is to create that behavior in a consumer. And then you're saying, well, they don't care. Yeah. So fortunately, to answer your question, I believe that the best solutions to our problem are solutions that don't involve more taxpayer dollars being thrown at the problem, which is fortunate because, as you pointed out, we don't really have the dollars to throw at the problem, right? So I think being more efficient, being more transparent, sort of removing some of the restrictions that have kind of hobbled the consumer and hobbled the provider in terms of exploring new methods of transacting business, if you will. Direct primary care, I'm a big believer in that. I think that when you allow patients the ability to choose a doctor and to basically have an arrangement financially that works for them, that works for the physician. Every physician that I talk to, primary care doctors, remember when I started my training as a doc, primary care doctors by and large were so unhappy with the system as it was, and the prior authorizations and the just unbelievable bureaucratic red tape that they had to go through in order to get paid. Yeah. Every single doc that I know of that does direct primary care is literally the happiest physician I've ever met. Being freed of so many of these burdens and being able to sort of see the number of patients that they want. You have to keep in mind that under the capitated HMO model, PPO model, traditional insurance model, patients literally have to be crammed into these primary care practices at 5 to 10 minute intervals for some of these practices to be financially viable.
Right.
Because the reimbursements are low and the paperwork and the bureaucratic requirements as far as your back office are so high. So I think DPC is a huge part of the solution. I think transparency, we've already kind of beat that pinata up pretty good, but I think obviously we can never beat that drum enough, because that is
I don't think so.
That is, I think, the linchpin to all of this. Telemedicine also holds a lot of promise. One of the issues that we have in Texas is that we don't have a large enough health provider workforce. And so people are leveraged. When you look at the government insurance, particularly when you look at Medicaid, you're talking about 50% participation rate in a lot of specialties. It's terrible. We need more providers. So telehealth provides an opportunity for providers to be able to offer services to more patients without having to set up an expensive, costly, overhead-heavy brick-and-mortar business in a community that may or may not be able to support that.
Yeah. And for those of you that don't know, the average overhead for a primary care physician is, in a traditional insurance setting, is 40%. 40% of their revenue is dedicated to collecting the money for the services they've already rendered. So it really just becomes it's such an administrative burden that it creates that unhappiness. Dr. Buckley.
Well, not to sound cliche, but you always hear the saying that the states are laboratories for innovation. Mm-hmm. Let Texas be that laboratory. Mm-hmm. Let us decide to basically build our own pathway to make sure that folks receive health care. We talk a lot, and I've read a lot of the stuff that you've written and other folks about health insurance, and it sort of sucks all the oxygen out of the room. Well, I've had health insurance. I've been pretty blessed. I've been able to provide health insurance for my family for a long time. And not one time did it guarantee a whole lot of health care. I mean, it does not guarantee, we were able to do it. We're able to take off work. We were able to, have someone cover for me at the clinic. My wife could leave her job to take the kids. But for so many people, that is not an option. And that's where I think some innovative strategies where we can take, those are the most vulnerable among us, and not look to government and some heavily bureaucratic, expensive program that, I'll tell you how I got here. It's not that I'm some healthcare expert, but all the time when I was looking at running for office and being a member of the Texas House and being a Republican, I had folks come to me, why don't you just expand Medicaid? And I wondered, why don't we expand Medicaid? Yeah. Well, the part of me that actually, I do study, I'm a little bit of a nerd. I said, well, let's look and see. Why, what happened and where they did, what's happened where they haven't, and let's see if there's maybe there's a good case, maybe we should, right? Well, when you look at that, what I found doing some, simple reading is that basically nobody got more health care, nobody got healthier. If we want to expand insurance and pat ourselves on the back and walk away and say, oh, we did it, take care of yourself, to me, that's not what I do as a human. I want to make sure any decision I make actually solves a problem we have, and I'm specifically interested in helping solve problems for those that are less fortunate. The good Lord has blessed me beyond what I deserve, and so I want to try to put in place with my vote, my single vote on the House floor, and join gentlemen like Tom to come up with a strategy that actually provides that care. I'll give you one thing, and I told David this one time, and this to me sealed the deal on the Medicaid deal for me. I was doing a radio show, and it was pre-election, and I was there with a Democratic nominee, or not a nominee, but a primary candidate for Congress. It was kind of a weird setup, a physician. And we're visiting about different issues, and during the break, she kind of leaned over and said, well, I don't understand. Why don't y'all just expand Medicaid? And I said, I hear that all the time. I said, Doc, tell me in your practice, primary care physician, tell me how do you, I talk to so many physicians, they can't make it work. How do you make it work? Her response is, well, we don't take Medicaid. So You know, I mean, it may make a lot of us feel better, and it's a great campaign slogan and all that, but there are better ways. DPC, empowering patients and doctors, actually connecting. You know, you got to have a patient and a doctor to have health care, right? I mean, you got to have if we don't do something that strengthens that bond and creates that opportunity, then we'll miss the mark.
Yeah, I appreciate that. Thank you.
Went too long.
And I think it's important to understand. Does health insurance have its place? Sure, absolutely. I wish it functioned more like insurance, but we need to look at other options and offer other choices. Healthcare is incredibly local, incredibly personal, and everybody's needs are different. There are non-insurance coverage options that are wonderful. That's what I use for my family. I tend to walk the talk. And it works out well. It offers me the ability to have the peace of mind that I need if something bad were to happen. And that's what we want. We want peace of mind, and we want the ability to be in charge of where we go and what we need to see and who we want to go see if we know of a good doctor that we think provides good quality. We started the talk on Medicaid expansion, and that's just going to be an incredible push. We talked about DPC. I know there's some bills out there. What are some other? How do we deal with those that are vulnerable, those for whom Medicaid was intended, rather than bringing in more able-bodied people? How do we take care of the eligible women, the children, the disabled, and the elderly? Because we don't want them crowded out.
Sure. No, I think you're exactly right. I mean, and I think that's a good people, a moral people, and ethical people are compassionate people, right? And they recognize the need to care for those, and those are conservative values, mind you. But we need to do it more efficiently, and we need to come up with a better model, right? I mean, I think the canary in the coal mine is that if you have about 50% participation rate amongst providers for Medicaid, as Dr. Buckley was saying, that tells you something about the current system as it is. Reimbursements are low comparatively. Most doctors I know that take Medicaid either take a small percentage and then count on the commercial insurance to basically sort of subsidize the under reimbursement that they're getting from government payers, or they basically have a practice set up sort of like a mill, basically, where patients are literally just pushed through the clinic at breakneck speed, seeing ancillary providers whenever possible, and it's all about volume. If we can see 300 patients in a day, we might break even, kind of thing. That is no way, in my opinion, to care for those that are, most vulnerable.
There's no dignity there.
There is no dignity there. There's also, I think, questionable quality there.
Yeah.
So now, I don't know, and I've thought about this a lot, I don't know that you could ever get to a situation where you could fix the reimbursement issue enough that it wouldn't literally break the bank and make the appropriators pull all their hair out and scream, because it's just that costly. But the other side of that coin is, could we innovate? Could we come up with a better mousetrap that maybe removes some of the bureaucratic hurdles and red tape and actually is more efficient, a different payment model, a different system that gives, instead of giving patients coverage, perhaps what we do is we give them dollars and we tell them to go out and purchase their own health services. These kinds of things actually incentivize smart consumer behavior and reward good providers. And I think you'd have a higher participation rate if the system was shaped like that.
Oh, we currently do that in our food stamp program.
Right.
We give them preloaded cards, and they don't have to go to in-network grocery stores. They just get what they need as prescribed. You talked about 50% of providers. Actually, the number of physicians in Texas that take new Medicaid patients is actually only a third of physicians. Now, we talked about the reimbursement, but many, and the reimbursement is an issue, I'm not going to lie about that. But many of those physicians have said, I don't really mind the reimbursement, it's just that the administrative burden is so high that it ends up being a cost to the practice. And so they just can't afford to see those Medicaid patients. Well, we need to change that. We need to create an environment, as we've talked about, to incentivize those people who want to care for patients. On the other side of the coin, let's talk about patients. Did you know that in the state of Texas, we have nearly 600,000 people that are eligible for Medicaid that are not enrolled? We have to ask that question as to why. And how do we care for those people? Because obviously they're eligible. And transparency, lower prices, certainly. But it's got to be more than that. But that number, that nearly 600,000, that's among the number of uninsured. Well, we talk about wanting to help the uninsured. These folks are eligible for Medicaid. Let's focus on that group as well. Dr. Buckley, you have any thoughts on?
Yeah, I think so. I think, to reach out to folks, I like the idea of innovative strategies where we connect doctors to patients. And I kind of spoke to this earlier. And I think that one of the ways we can do that is by, when you look at a lot of the healthcare costs, it comes from, chronic disease and certain lifestyle choices folks make along the way. And I think that as a strategy to not only provide better care, but to also reduce care in the future and the cost of care in the future, why don't we leverage the power of telemedicine that we've really been forced to expand upon during the pandemic? And let's connect vulnerable populations via telemedicine to a doctor that can not only see the patient, but also see the environment that kids are being raised in. Think of the young mom who literally is working by the hour. Can she take off 3 hours during the day to go to the doctor? I mean, it hits her, right? Mm-hmm. But if you can build a connection there, if it's something where she has a relationship with a provider and you have given her the choice of doing that, she can then link that provider into her household, if you will. And that, to me, that is a way to begin to help advise her on good nutrition, on preventive care measures, on lifestyle choices, on behavioral choices, all sorts of things that can improve the quality of life for Texans. And to me, that's a key way to do it. And I think that there's so many physicians that I talk to that are really wanting to experience that. Because let's not forget, if reimbursement is the only problem, and you up the reimbursement, a lot of folks that favor expanding Medicaid will say, well, heck, it's a 90-10 match. Let's just put 90% on the federal credit card, and we'll pay the 10. But the problem is if you increase reimbursement in a state budget, where are you going to take it from? You want to take it from education? You want to take it from roads? Let's have an honest conversation about it. It's not this panacea that fixes it. Again, a program like that, to me, takes the most vulnerable communities and it says, we've done our part. Right. And I spend a lot of time there. My district is full of folks that are very, very much less fortunate than me. And the last thing I want to do is say, don't worry about it. They'll handle it over there. Those communities, they don't want that. Mm-hmm. I'm telling you, they want to be a part of that. Those folks that can want to be a part of caring for their neighbor. Mm-hmm. And to me, these systems of direct primary care and empowering a doctor and a patient and building a system and a strategy to do that, that to me is a huge step forward.
I appreciate that. We're getting so many good things out of this. To frame it for you all as you walk away, if you don't remember much of what's said, you can always go back to the video and watch it. But you can also think about it in these terms. Rather than having a reactive sick care system, let's have a true healthcare system.
Amen.
And let's focus on giving people the ability to reach out. Talking about the Medicaid population, what happens now? What's happening now is that many of these people, because of transportation issues, because of childcare issues, because of just perhaps not knowing and lack of education, where do they end up for their care? They end up in the emergency room. Yeah. Not only is that bad care, having run a number of them, emergency rooms are great for what they're designed to do, is treat emergencies. They're not great at primary care. And the majority of our Medicaid beneficiaries that go to the ER are non-urgent. But it's one of the places they can go to get a relief to whatever pain that they're having. We can do better. But not only is it not the most optimal care for them, it's also more expensive. So we can certainly be more efficient. And I think we can address some things there as well.
David, it's funny you mentioned that. I will, never forget when I was an intern at Ben Taub Hospital in Harris County on my medicine ER rotation, working there in the Level 1 Trauma Center, taking care of patients came in with medical emergencies. And one night I was on sort of the lowest level, which is what they call the halls, which is just basically people coming in for non-urgent stuff. And it was a Saturday night, and at 2 in the morning I had a patient that came in, and he was getting his eye drops refilled for his glaucoma. Eye drops, right? No shortness of breath, no chest pain, no abdominal pain, no broken arm. I just need a medication refill, doc. And I remember asking him, Mr. Jones, I'm happy to refill this for you. It's good to see you. You need to follow up with your primary care doctor. But by the way, what on earth are you doing at a Level 1 trauma center at 2 a.m. on a Saturday morning getting eye drops refilled? And his answer floored me. You know what he said? He said, if I make an appointment to see my regular doctor, I can't get in to see him for 3 to 4 weeks. And when I go to the clinic and I spend literally half a day there because I wait to see the doctor. When I finally get in to see the doctor, it's an hour after my appointment time, and then I have to go to the pharmacy and fill my prescription, and then that takes another 2 hours. If I come here at 2 in the morning, you see me within 30 minutes, I get my prescription, I'm out the door. That's why I'm here. And I thought to myself, how dysfunctionally broken is our system, our care net system, our safety net system for these folks who are vulnerable, that this gentleman would rather come to the Level 1 Trauma Center at 2 in the morning to get eye drops than go and see his regular doctor. And I have never forgotten that story, but that's exactly what you were just saying.
No, I can tell you, one of the busiest hospitals in Houston, when I was a young administrator, we were studying what the primary diagnosis was. And for a given month, I think it was 67% of the diagnoses, it was otitis media. It's middle ear infection in the ER. So can it be more efficient? Can it be more optimal? Absolutely. But we also want to care for these people. We don't want to treat them as poorly as we have and restore the dignity with which we provide services and care to those that we say we want to care about. Gentlemen, any last words before we take the questions and answers from the audience?
I have one. If there's never been a story or a situation, something explained that doesn't sort of make the case for a free market system in an important segment of our life, it's the one that Tom just shared. Because I can tell you in my free market world, if I made somebody wait half a day to do something, they would be scooting right down the road. And so
They'd probably have their dog bite you too.
they probably would, and probably leave a mess on the porch of my clinic. And I deserve every bit of it. Because when you take that away, when you take away the forces that make us want to be better, to deliver better care, to be a better practitioner, to provide better client, customer, patient service, when you take that out of the equation, that's what you get. And so why we keep thinking that somehow this won't apply to this segment, I have no idea. Because I live in this force, in a market force in my profession, and when you look at rankings, veterinarians are always seen as those that care more than any other profession. And I'm there every day to make a living. You know what I mean? I love animals. I love what I do. But I'm there to make a living, just as our physicians are. But, in other words, you can do that. You can provide market forces in a profession, real market forces. And the Tom Oliversons of the world, they care so much. And they will, they will be there to provide that care. And so, I don't know. I can't understand how we have just totally divorce those two things from
Yeah.
each other.
Well, and
Anyway, sorry.
Yeah,
No,
good
thank you very much.
Good
I
stuff.
appreciate it. And speaking of caring, I just want to take an opportunity again, Dr. Oliverson, to say thank you for the effort and time that you put in during the pandemic, spending time taking care of patients. Let's open this up for questions and answers and take some opportunities.
This is Jim Lennon from the Kingwood Tea Party. Gentlemen, you very clearly stated what your goals are. They need to happen. What are you going to do this legislative session to achieve those goals?
Always to the point, my good friend Jim. I would just tell you that we file legislation. That's what we do. We actually file legislation to make some of these things a reality.
We're just looking forward to helping support those, and what are they?
Well, we are in the process of working those up right now. So we have legislation working on transparency. We have legislation working on expanding the role for direct primary care, telehealth. One other thing I should throw out there is just, I think it's important to remember as conservatives that, when we talk about safety net and we talk about the uninsured and we talk about providing care and how do we do that and, who's responsible for that or should we be doing that at all, we should never forget that people that don't have access to health care through whether it be insurance or Medicaid or whatever it is, but people that don't have access to the system, to care, they still get care. It's just, as David pointed out, and as I gave you an example, it's just ungodly expensive care, and it's terribly inefficient, and it doesn't lead to good outcomes. But in a lot of ways, some of that's already baked in the cake in what we pay as taxpayers for health care in this state and in this country. So there are opportunities, I think, to take dollars that we're already spending, that the federal government is spending, and use them in a more thoughtful, efficient way. And I believe that if we do that, that the state will actually experience a savings. Because that care that's already being provided in an extremely expensive and not very efficient manner will suddenly be provided in a way that leads to better health outcomes, better patient satisfaction, better compliance, better provider participation rates, and less ER utilization.
Yes, you've talked so much about transparency, but you always put the word hospital after it. I want to know if the transparency that executive order that came out of Washington applies only to hospitals or to all providers, and also if Texas is able to legally increase the penalties for people who do not comply with that transparency ruling.
I can start off with the answer to the question about the order. It does apply to hospitals. There will be another implemented order in, I believe it's 2022, for insurers to do the same thing. It really, again, discloses that negotiated rate between hospitals and insurers. Now, as far as the providers, de facto, yes. If you're an individual provider not affiliated with a hospital, no, that rule does not apply to them. But I believe now the number of physicians that are employed by hospitals is roughly 60% around the country. So those prices would be disclosed by virtue of the fact that they are employed by the hospital.
And increasing the penalties?
I'll defer to you gentlemen on that.
I would have to defer to the legal minds in the room. I'm not sure if
Yeah,
the state can do that
I
or
think
not.
we can do
I
whatever
don't-
we want,
Yeah.
right, as a state. I would just tell you from my perspective, so I think the reason that it was structured the way that it was structured is that when you look at the size of the bill and the potential for, sort of financially ruinous, life-changing debt experience on behalf of a unsuspecting consumer, the facilities charges are the ones that really bankrupt people. Yeah. Not to say that providers don't have a role to play in that, they do, but just if you compare the size of the bill, if you have an appendectomy, appendix removed, what your surgeon gets paid, what your anesthesia provider gets paid is an order of magnitude lower than what the facility gets paid in most cases. So I I agree with you. I think, what's good for the goose is good for the gander. But I just want to point out that I think the reason that the Trump administration did it the way that they did it was because they were trying to get the most bang for their buck, to get this rolling and get this out there and then expand from there.
And the question was, can Texas raise the $300 penalty for noncompliance so that there's teeth?
I don't see any reason why we can't. It's just going to be a matter of getting the right legislation, the right wording, but then having the appropriate penalty attached to it. So yeah, I think that that's something that can and should be done. Dr. Porter?
Thanks. Add direct dispense to that legislation as well, My question is a little different, is that I've been doing early COVID outpatient treatment, and because I'm independent, I can do that and look at the research. Physicians who are working for large corporate groups or government have been prevented, threatened of retaliation for doing things that are a little bit outside of the box. And Dr. Buckley, I've had some interesting conversations with patients who wanted to use horse ivermectin.
Absolutely.
So I'm trying to. I'm a people doctor, but no. I appreciate what you do. But there have been cases, particularly in other states, where they're going after independent physicians for actually, showing some, initiative and trying to get COVID treatment early. What can we do to prevent politics and retaliation against physicians locally?
Dr. Porter, you just got the prize for the $1 million question. Friends, I can't tell you how sad I am. And just sort of, shake my head every day when I look at the headlines, if you just Google COVID, at the immense politicization of this pandemic. The fact that this occurred in an election year, it's truly disgusting. It really is. As a doctor, you and I can look at a study and we can determine whether it's valid or not valid based on the quality of the study and the conclusions and things like that. And there has always also been a role for off-label use and trying things, especially in the midst of a situation where people are dying, people are getting sick. We're still trying to figure this out. We're still trying to figure out what works and what doesn't. We need all hands on deck, right? It's just been an incredibly frustrating experience to watch medicine essentially be weaponized by both parties, quite frankly, on the left and the right. And I'm sure you've noticed that, the other thing I would just throw out there, and you probably noticed this too, it just drives me up the wall, is the degree to which the internet and social media in particular have absolutely destroyed the scientific method in terms of being able to get truthful, accurate, reliable data to the public. I mean, it is a brutally difficult time, I think, to be a chief executive of a city or a county or even the country when you got legions of, quote, experts with their Google medical degrees coming in and pointing to this study or that study, and you've got, I'll use the term not lovingly, knucklehead doctors who are basically taking results from studies that have not gone through a peer review process, who are pre-publishing that on Twitter and Facebook and getting attention that they, quite frankly, don't deserve, and misleading, I think, the public. And so it's just all over the place. It's just a total mess. I've never seen anything like it, and I will tell you that I am deeply disturbed and concerned as a physician scientist about the future integrity of the scientific method as applies to medicine unless we can get social media out of it.
Wow. Amen.
And political experts.
Correct.
Yes, sir. Oh, let's wait for the mic.
You talked about 600,000 that are eligible but not registered. I'm wondering if a lot of those were probably on some other program as well that we might be able to use to get them registered?
I'm not sure I understand the last part of your question.
Well, the question, I would think that besides Medicaid, they probably may be on some other program, government program.
That actually comes from the breakout of the number of uninsured in the state of Texas, according to the Kaiser Family Foundation. So they could be on something. So, personally, I have a sharing ministry, cost sharing
Right.
type of product that I use for my family. Because it is not insurance, I'm technically uninsured. So could they be on something else? Absolutely. Could they be part of a direct primary care clinic where they're getting care but they don't have that backstop coverage? Certainly. Does it mean that they're not getting care? No, it doesn't. But that's, that population of the uninsured is the one that's driving all of the attention. And it's the reason for bringing up that statistic was to identify that these folks are eligible for some form of coverage, of insurance, and they're choosing not to. Why? And so that's the reason for bringing it up as it is.
Well, no, just wondering if there's a way that if they're not registering, not maybe getting coverage, if there's another way to get them, to help them get that coverage.
Well, and the other question you need to ask is, do they find value in it? Because, look, why go through the process of application if they're just going to end up in the emergency room anyway? They can just go to the ER without having to go through all the paperwork.
That's the key question. Do they find value in it?
Yeah, it's the question. It could be any number of things, and I don't want to, with a broad brush, say this is why. There could be any number of reasons because, again, those decisions are personal and they're local.
But we could clearly say that those individuals who are eligible for it don't find value in it sufficient to register for it. Bottom line, right?
Yeah. Then I think that there could be some other reasons. Are they educated enough to know how to? And I think that's a much smaller percentage, but by and large, I think it more is a question of value. That's my personal belief, just from observation and anecdotally from people that are in the field.
Could be the fact that when only about 50% of the physicians will accept a Medicaid patient, they have experiences with friends or folks that they know of bad outcomes or bad service, and they're not accessing that. And in my mind, I'm a pretty simple thinker, but if you take, the more folks you put in that line, the more folks that are going to displace. And and so I think that there's a lot of that. I think it makes a great case for creating something that people see value in, that they want to be a part of. And that vulnerable population needs something they feel like they can count on that will provide them what they need. And I think that, again, that's a probably very diverse group. But what is it that keeps them from seeking that care?
And I think it's important for us to say that the folks that want Medicaid expansion, I think that their motivations for the most part are good. They want people that are uninsured, that are low income, that don't have access to some kind of insurance, have some kind of insurance. We just don't think that that's the best approach. We would prefer that they have better forms of access by making healthcare more affordable. Affordability is the biggest obstacle to access. So let's hit at the root cause as opposed to focusing on putting an insurance card in people's pockets that they may never use. This gentleman over here had his hand up.
I'm running. I know, I get myself.
So I heard a lot about for the upcoming legislation that's going to improve healthcare. But the comment was made earlier, wouldn't it be nice if insurance acted like insurance? And just a little bit of an anecdote. So I actually work at Dr. Porter's direct primary care clinic. And we had one patient came in for COVID testing, so cash paid, but he asked for an invoice to take to insurance company. Sends the invoice with all the proper notation on it to the insurance company. Week later, patient gets a call from the insurance company. Hey, can you verify these numbers on the form? So another half an hour conversation with the insurance company. Week after that, the insurance company calls the clinic to verify the same numbers. And then another week passes. Hey, can you send this additional document to the insurance company? So under the CARES Act, the insurance company has to pay for it because it's a COVID-related test. But they're spending at least a month not reimbursing the patient.
That's a problem, right?
Yeah, remind you of
I mean,
I'm from the government and I'm here to help.
Yeah, so So, and let me just sort of add a little, overview, back out just a little bit more and get a bit of the whole picture. So he's haggling for more than 30 days with an insurance company over a test that they probably charged $100 for, maybe, I don't know, but let's just say roundabout probably, which is a reasonable price, when you look at the marketplace for something like that and what's going on out there. That's a market-sensitive price. And so he's waiting to get paid, having charged a fair price, and then we have providers out there. You go to the certain facility, and they say, "Don't worry, we'll bill your insurance. You don't owe anything today," and they send a bill to your insurance for $10,000 for the same test, right? And so we have both extremes under the quote CARES Act going on right now. And it's just incredibly frustrating. And I think, when you talk about ways that we can save and ways we can make our healthcare system more efficient, David, you and I talk about this all the time. We're definitely not in the business of helping those that are unscrupulous preserve their business model.
No.
We're here for savings and we're here for patients.
That's right. That's right. Funniest story, we'll go to Robin next, but I wanted to tell just a quick story. Speaking of an insurance company and a patient submitting the bill, and then the insurance company, in doing their due diligence, sends a letter to the doctor, to their office, saying that they required a piece of information in order to process the payment to the patient. Guess what they needed? The doctor's address. Well, they just mailed a letter to his address. So it's just, there's a lot of, the level of ridiculousness is pretty high. But it makes for good entertainment sometimes. Robin.
I was a Birthright Center volunteer for years, and so we would offer pre-pregnancy tests to young women that thought they might be pregnant. Well, some of them would come over to us after having been to the county clinic that was like down a block and over. And they came into us, and we had some of those girls crying to us, telling us how nice it was to come talk to us who treated them like people. So some of this thing about them going to the clinics and not wanting to go back, I mean, when you take the vulnerable population that already has self-esteem problems and then you treat them like that, I wouldn't go back either.
I'll tell you what, though, also, but when you're you're a provider and you're in a situation to where you're not being paid adequately for the job that you provide and the services you provide, and your staff is underpaid and they're overworked and they're stressed, that's what leads to poor service. Again, the market, puts a smile on everybody's face because you're competing. I mean, again, so a great, another really good question, a great example of why we need that in the system.
And then we'll go to Dr. Robinson afterwards.
This may be the wrong form to ask this question, but I was just curious. Let's say my wife needs to go get a mammogram. I can call where she's been sent and say, okay, what's the cost of this? Well, under insurance, it's this, but if you pay us, let's say it's $1,200, but if you pay us cash, it's $300. And then I've got to make a choice. Well, do I want it to go against my insurance deductible, because I still have a deductible regardless, or do I gamble and spend $300 cash and assuming that maybe I'm not going to reach my deductible anyway? But why is that? Why is there such a huge dollar amount between paying cash and going through insurance?
Well, I think two reasons. I think that's a great question.
It is.
And I've actually filed legislation on that very issue before, and you just reminded me I may need to do that again. But basically what it boils down to is that when I can get paid instantly and I don't have to file a claim, that's that 40 to 60% overhead that David was talking about earlier just evaporates. And that's one of the reasons I think why direct primary care doctors are so happy and very comfortable in their practice, is that they've eliminated that overhead. They don't have to worry about claims and haggling with companies and stuff like that, because they're getting paid on the spot. Now, if you're a consumer and you're listening, I would tell you that as a smart consumer, you should always ask what the cash price is.
Always.
Always. Because you may be surprised. that it may be a significant savings, more so than what you would think. And what I have always believed and will continue to believe and continue to work towards is that I think that if a patient wants to act like a secondary negotiator on behalf of their own insurance company in their own best interest and find a better deal, I think they should be entitled to part of the savings. I think at the very least, they should credit that payment towards your deductible in full. But actually, honestly and truthfully, if we're really just being fair, since they're now doing the work of negotiator as well, I think that should be reflected in a savings for them in terms of lower premium costs or lower deductibles in the years to come. Now you're actually empowering consumers to be shoppers and to be savers. And I think that actually bends the cost curve down significantly. It's a great question.
Good question. We have time for one last question. Dr. Robinson had his hand up.
This is directly for you, Dr. Oliverson. Dr. Porter asked a question that I think had an element about Dr. Dispense, which I believe is being filed again this time. And I'd like you to speak to how you feel that might be a good idea, since there are, I believe, 45 states allow some degree of it. Just speak to how you
Sure.
think that might be an improvement for patient access.
So I have filed that bill, and my colleague Matt Shaheen has filed that bill in the past. We both have worked on that. Strong believers in that. TPPF is a big supporter of that. David and I have worked together on that. He's actually, TPPF has actually been very helpful to both Representative Shaheen and myself on that issue. It is already legal in a certain area of Texas around Midland, Odessa, oddly enough, but not statewide. And you correctly point out that Texas is one of only 4 states currently that doesn't allow for that. And look, I just think from my perspective, where I see it maximally beneficial and kind of what I was interested in my legislation is with regards to direct primary care. The physician is already being compensated for their services, and so the idea becomes then, what kind of value can I also bring to that physician-patient relationship outside of just that direct primary care visit? And if one of those things is that for the top 30 medications that I'm likely to prescribe, that I can get those medications in the patient's hand at the time of their visit so they don't have to go to a second location and get it filled, which improves patient compliance with medications, and I can do it essentially at wholesale acquisition cost, my cost. No dispensing fee, no marking it up, no paying the PBM, no crummy pharmaceutical rebate that increases your cost of health care but gets a big fat check going to your employer at the end of the year. That's a huge win for people. That's a big win. So I am fully supportive of that. I expect that is going to be legislation that moves this time. Obviously, there are some folks that don't particularly like that legislation, and so it's one of those things. That's what we do, right? We work to get things that are meaningful passed, and we have to overcome difficulties and resistances and fight for the things that matter. So yeah, I'm all for it.
Let's give our panelists another round of applause. Thank you, gentlemen. I know that there were more questions. I'm sorry that we couldn't get to them all, but we do have some resources online. If you go to texaspolicy.com/ROH for Right on Healthcare, you can sign up for our newsletter. We also have a private healthcare, our Facebook group, where there are always dynamic discussions going on about different issues. We'd love to have your involvement. And of course, if you have any other questions, I'm more than available. I'm happy to discuss them with you.
And thank you for what you do here at TPPF.
Here.
Thank you. I appreciate it.